We try to limit this one. We don't have some more depth to talk about with the fire.
Okay, my name is Antonio Lister. I'm actually I'm a nurse at one of the hospitals in the ER, as well as a nurse in the flex pool at one of the other hospitals as well. I have my associate's degree, and I'm actually trying to get my bachelor's degree. And this is part of our assignment to get our bachelor's degree. Basically, what we have to do, we have to do a staff development class, and basically teach a class on things to increase the competency or the skills or the knowledge of the nurses that, you know, depending on the institution or facility that you're working for, or doing your preceptorship. So today, what I decided to do, I was going to do my class on wounds. And the reason why I'm doing it on wounds is because as nurses, we often encounter wounds in different areas and different settings. But in home health field, they actually encounter wounds a lot more, just talking with friends and things like that. And being an ER nurse, we see wounds, we see them, write something down real quick and send it off to the floor. You know, that's how we do. And once we get to the floor, it's almost the same principle. We kind of look at them and kind of just give our own objective opinion about what the wounds are. However, when we talk about wound management and wound care, there are a lot of implications whenever we grade the wounds wrong or whenever we classify the wounds wrong. So this is just kind of increase our knowledge and skills. It's a very brief overview. I'm sure most of you probably know about wounds a lot more than I do, but hopefully I can give you a little insight on what it means for wound care and wound management, or how to treat them or how to care for them. Like I said, it's a very, very brief overview. I actually had handouts for everyone, and I apologize, I left them at home, but I will get them back to you. We're just going to talk about just basically what are wounds. You know, wounds can be anything from just a simple cut. Also, wounds can be just skin tears. Of course, you know, like the elderly people, as they age, the skin becomes more fragile, so the skin tears a lot more easily. That's also considered wound. Contusions, or just a bruise, we consider that as a wound as well. Skin flaps are considered wounds. There are also what we call surgical wounds. You know, when the surgery team goes in, they do surgeries on patients, they make certain cuts, those are considered wounds as well. The surgical wounds, and they have their own classification system. You know, for instance, class 1 may be, it's just clean, and what they mean by clean is they didn't have any break in surgery technique. You know, it's clean, doesn't have very, very little chance for infection. You have class 2, which is going to be clean, contaminated. Maybe they have maybe just a minor breaking technique, but still, you know, it's not real likely to have any infection. Then class 3, of course, as you go down, becomes more and more prone to infection. Class 4 is what they consider as dirty. And basically, like you have a stab wound, gunshot wound, that patient falls down on the ground, rolls around, that's dirty. So when they go in and make those incisions there, you know, the aseptic technique kind of, so it goes out the door a little bit because they have the pre-existing contamination that's already there. Next we have burns. Excuse me. You know, burns have their own classification. So of course, you know, you have your first degree burns, which is going to be just like your sunburns, usually lasts 5 to 10 days. Some cream, you know, is very, very tender. Your second degree burns going to be like your partial thickness to full thickness burns. That's where it affects the dermis and the epidermis of the skin. Third degree burns, of course, it keeps going further, it gets worse and worse. You know, in the classification third degree, the symptom that's most likely with that is usually no pain, which is third and fourth degree burns for the simple fact that there's a lot of nerve damage. And when you have a lot of nerve damage, of course, the pain receptors are not there. Of course, then the care for those is, you know, becomes increasingly as well when you have the third and fourth degree burns. And so, of course, there's a lot of debridement and creams and things of that nature that you can use. However, in the nursing world, you know, of course, our main focus a lot of time is on the pressure ulcers. You know, those are also considered wounds as well. So when you have the pressure ulcers, you know, basically that's where the soft tissue is kind of compressed between like the bony prominence, let's say, of the sacrum bone and like the chair or the bed. So it kind of compresses that skin. That's kind of what produces the pressure ulcers. And of course, you know, we always document, once again, like I said, they come in, we see them, they come in from the nursing home, we look at them real quick, we send them off. Same thing, once they get to the floor, depending on what floor you're on, some nurses are more apt to actually telling exactly where it's located at and doing a proper assessment, which is what we want to do. And the reason why is because there's implications for us, like even now with reimbursements, you know, because if we don't document that we've seen the wound, where it's located at, the correct grade and classification, we don't get reimbursed for that if they go home with that. And actually, we kind of eat those costs. So it's very important and essential that we document and assess those wounds correctly. And so as we, you know, begin to, the purpose of this class is just kind of give an overview, because what we found in research is, you know, you can take a group of nurses, present them with wounds, and each nurse classifies or grades that wound to a different thing, you know, and then depend on, some nurses learn this classification system, some learn it this way, some learn it that way. And what they were finding out was, not only were they all classifying it differently, most of them were classifying it wrong, you know. And once again, you know, depending on how you classify a wound, it's going to determine how you're going to treat that wound. And if you don't treat it correctly, then it can get worse. And then if as it gets worse, that means longer hospital stays. That means increased psychological and emotional decline for the patient. That patient is actually a working patient. That means loss of wages, because now he's in the hospital longer having received antibiotic treatments because baby became septic, so he's not able to work as well. And so once again, if that wound is a cause of something that we did, then we have to eat those costs. So it's a financial strain not only on the patient, but on the financial institution as well. And so that's one of the things that we have to be, you know, mindful of. And so the thing is, it's kind of hard because most studies show, I did not mean for that to happen. Most studies show that, I kind of lost my train of thought now.
And it's going to be on YouTube.
But, you know, where was I? I'm sorry. Yeah, well, with the reimbursement, most studies show that I completely lost my mind now.
Give me all right.
Yeah, we'll go back.
You can cut that out.
Yeah. So when, like I said, whenever we're dealing with the pressure ulcers and the reimbursements, oh, I know what I was saying. Messing with me. I feel like I'm a real teacher now. So what happens is, you know, like I said, reimbursement is important. We have to grade those wounds appropriately. And so as nurses, you know, like I said, it depends on where you're at and what location you're in and what hospital and what institution you work for. There's no general consensus right now as far as how to grade wounds, because they're looking at, some people are looking at just having two classifications. Is it deep or is it not deep? And that's the classification system that they go by. It's a lot easier, but it doesn't actually give an entire assessment of actually what's going on, you know. But within our institution, or with the institution that you're in, it's important that at least that institution, whether it be nurses or registered nurses, LPNs, doctors, whomever is dealing with their patient, they all have the same idea of what a wound is, so that way the continuity of care is not broken. You know, you don't have one nurse saying it's this, and then the next shift comes on and says one says it's grade 2, the next one says it's grade 3. You know, which one is it? Because you may have to treat those differently. You know, and of course, if this nurse saying they came in with a grade 2, and now this nurse is saying that it's a grade 3, now insurance company's going to be looking and say, hey, well, you didn't do your job. As far if it was a grade 2, it should be getting better, not getting worse. So if it's getting worse, it's something that you did. So we're not going to reimburse you for that. So we need to make sure that we're all on the same page. And that's what the point of this class is. It's just kind of creating awareness of where we are as far as in caring for our patients, and that we all begin to be on the same page, that no matter which nurse within our institution, they will all grade the wounds the exact same way. And like I said, it's important for us because, you know, we want to make sure that with the financial part of it, but it's also important for the patient as well. And that's the main thing, is the care of the patient. We want that patient to get better. We want to provide them with the best care that is possible. And so, like I said, that was the basis of this class. That's basically the summary of it. And, you know, if you guys have any questions, the floor is open, so you can feel free to ask me any questions now if you want to.
No.
Okay, and that's it. All right, guys, I thank you for your participation, and that is it. Thank you, ladies.
You're very welcome.